Good morning, one and all. So, today I think even more than perfecting the skills in cataract surgery, which I think most of us are confident in, it's really the outcomes are improving primarily because of the improved formulae and the devices that we're using to measure it. So, over the next few minutes, I'll try to highlight the most salient points of these aspects and how we can take it forward. So, we've had run through various generations of IOL formulae. While the older generations primarily relied on K reading and axial length, it is the effective lens position which differentiates the newer formulae from the older. And that is precisely what is improving outcomes. Because the important goal is to find out where the IOL which we are going to implant in the eye is finally going to rest. Now, this is also not a fixed number because as you can see from this slide, it's not just that when you have a long eye, you have a large ACD, or if you have a short eye, you have a smaller ACD. Only 70% comply to that norm. Remaining 30% actually have different proportions. That is, the ratio between the axial length and the anterior chamber depth is quite altered. Therefore, determining the effective lens position for each individual eye becomes extremely important for us to get better outcomes. The Holiday 2 and the Haigis were definitely improvements where they started showing various other parameters apart from just the axial length and keratometry, but like preoperative refractive error, the white to white, the preoperative ACD, lens thickness, all of which were being included for the IOL power formulae. The concept was that when we have more variables, the more accurate outcomes that we are going to get when we do IOL power calculation. But I think more or less now, I think we've all moved on to these fifth generation IOL formulae, which is the Olsen, Barrett Universal 2 and Hill RBF. And I'll briefly highlight the salient aspect of each of these. In Olsen, the most important formula or the most important aspect here is the C constant. Now, the C constant is essentially the ratio where the IOL is going to rest in proportion to the entire lens thickness. As you can see here, now if you take this lens thickness to be 100 and if the C constant is 50, that means the IOL is going to rest exactly in the center. Now this varies depending on the axial length, the lens thickness and the anterior chamber depth, and therefore predicting the ELP becomes much more superior with the Olsen formula. Dr. Olsen claims that he does not have as many variables as Holiday 2, but it is important to have the right variables than having multiple variables. The Barrett Universal 2 is one which probably most of us are using now, and it is a thick lens formula. And the most important addition to this formula from the pre-existing formulae is the lens factor. It also takes into account the plane of the lens. That is, even when we go in for very low powers in high myopes, when the lens changes from a biconvex to a meniscus shape, the principal plane and the orientation of the haptic to the optic changes. And therefore, the optic tends to push back a little bit and the ELP gets altered. So this lens factor is also computed, and depending on the IOL power, the effective lens position can be calculated more accurately. And this is really an online calculator which is available for everyone. And we have more or less moved on to the Barrett Universal 2 for all patients across all centers. And the entire Barrett suite actually covers the entire gamut of patients. Your post-refractive surgery, post-RK, you have the Barrett TrueK formula. You also have the Barrett TrueK toric calculator, apart from the regular Barrett Universal 2 and the Barrett online calculators. And you also have the Barrett treatment formula. So if you have a residual power, you can go in and input with the Barrett treatment formula, and it will tell you to how much to rotate, whether you need to exchange, whether you can put in a piggyback. All these options are available with the Barrett Universal. Apart from that, in a more complicated case, you can also use something called the integrated K, where you can compute values from different instruments, from 3 different keratometers, using, let's say, for in this example, it's the IOL Master, Pentacam, and Manual K. And all of these can be used, and the average reading of this is then taken for computation in these patients. The most recent is the Hill RBF formula. Now, the Hill RBF is a complete step away from the traditional formulae, where it entirely uses artificial intelligence and pattern recognition. So, there's a large amount of data which is fed into this calculator using the LensStar equipment, and then subsequently this undergoes adaptive learning. There is still data being fed in, newer versions are coming out. It is continuously evolving and self-organizing. And because these are from a natural population data, it is free of any calculation bias. This is the earlier version of the Hill RBF where it was optimized for +6 to +30. And subsequently, this is, of course, the online calculator, the RBF calculator, which is available. Now we have the version 3, which really covers almost the entire range from -5 to +34. And apart from the traditional values, it is also showing that values like CCT, white to white, and gender probably have a small role to play as far as the final IOL power formula is concerned. So essentially, to conclude, as far as the formulae are concerned, I think we are all sticking to almost one formula for the entire gamut of our patients, whether it is a Barrett 2 or a Hill RBF. And all these are available as online calculators, and even irrespective of the kind of biometric device you have, you can use any of these formulae. Keeping in trend with the advancement in formulae have been the advances in optical biometry as well. For paucity of time, I'll just explain the more recent advancements with the IOLMaster 700 alone. Essentially, compared to the previous IOLMaster 500 or the LensStar 500, the 700 is essentially a swept source biometry. And the swept source OCTs are now gaining prominence, and all the newer biometers which are coming into the market are all swept source biometry based. And they are able to give us a true B-scan biometry, and therefore you get very, very accurate measurements of the corneal thickness, anterior chamber depth, and lens thickness, which was not as accurate in the previous versions of the previous iterations of the IOLMaster 500 or the other devices. It also has a foveal pit which can be imaged, and this really allows us to know whether the patient is fixating accurately or not. Previously, we had to rely on the patient to fixate. So just giving you a good example where the foveal pit imaging is good, you get very repeatable measurements, very minimal difference in axial length and keratometry, and the exact same IOL power. Whereas this is an example where you can see that the foveal pit is not imaged, and because of this, there is a significant difference in the measurements between two measurements in keratometry and axial length, and this leads to almost a diopter of difference in the final calculated IOL power. This, because of the B-scan and the swept source OCT, measuring the lens thickness accurately gives rise to better effective lens position and anterior chamber depth measurements in the pre and post-operative period, which was not possible with the IOLMaster 500. This has significantly improved repeatability and outcomes. Also, because of the swept source OCT, there is a greater penetration in these denser cataracts, and very, very few cases you are having to resort to an immersion biometry. Almost the entire gamut of cases we can cover with the IOLMaster 500. In keratometry as well, it has something called the telecentric keratometry, where essentially, even if the observer who's measuring it or the patient is not able to keep their head very steady, the distance between these spots is maintained. So even if there is a little bit of defocus, the area which is being measured on the central cornea remains constant. And as a result, the recordings are more repeatable. I'll just close in a minute. The most recent advancement is the availability of the total keratometry, where apart from the anterior measurements, anterior corneal measurements, you also have the posterior torus fit. So it gives us in separation the anterior keratometry, the posterior keratometry, and the total keratometry. You also have formulae which are now ULIP compatible, the Barrett formula, which is specifically for the total keratometry value, the Barrett TK. You have the Barrett TK Universal 2 as well as the Barrett TK Toric. Now, these formulae are specifically suited for the total keratometry, and you don't require any modification, and they give you the exact IOL power directly, and even the toric IOL power calculations can be made immediately. This has really improved toric IOL calculations in both regular as well as in post-laser refractive surgery eyes. And it is not just the Barrett-Truquet formula alone. Apart from the Barrett-Truquet TK, even the Haigis TK. So essentially, the different formulae, as when they incorporate the total keratometry value, it has been shown that it is superior to ones which are just measuring the anterior keratometry. You also get angle alpha, angle kappa values. But most importantly, it is these advancements in the biometry devices and the measurements along with the IOL formulae which is giving us the precise refractive outcomes that we desire in our cataract surgery patients today. And with this 5th generation IOL formulae, emmetropia for any and every patient is a real possibility. Thank you so much for your kind attention.
Thank you, Shreyesh, for that exhaustive coverage. Any questions for him? Any practical points that anyone has? You did speak about optical biometry and your choice of Barrett formula, but there are quite a few of us who do not have access to the optical biometers. In case it's an immersion A scan, obviously we assume that none of us are doing contact A scan and say autorefractometer. Do you think they can still get the benefit of these formulae, and how would you go about doing it?
Definitely. It's just that when in the online calculator, it asks you whether the data is provided by the optical biometer or the ultrasound biometry, and you'll have to use the immersion ultrasound biometry and of course use the immersion A constants. But apart from that, there is the outcomes can be quite similar. We have centers where we don't have optical biometer and only immersion is being done, but even there all the premium IOLs, torics, multifocals are all being done with almost similar outcomes to that of an optical biometer. So it's really the advancement in the formulae and the online calculator being available to any and every one of us, which is now enabling us to reach out to these patients.
So even if you have your measurements from the immersion A scan or the autorefractometer, you can go to the ACRS or APACRS websites. There's a drop-down menu, and you can have access to all these formulae and get the benefit of it. And in case you're using that, you have any suggestion as to what A constant they should be using, whether it's an acoustic A constant or a immersion A constant or a optical A constant?
Yeah, they should be using the acoustic A constant. That's what I mentioned, that both the acoustic A constant and the fact that you're using the ultrasound, there is an option for you to use the acoustic A constants in the calculators, and that needs to be entered when you're using your immersion device.
And another point I'd like you to clarify, we use the Barrett toric calculator as the go-to formula rather than Barrett Universal 2. Would you like to clarify on the logic behind that and why it should be done?
So essentially, especially when you're placing premium IOLs, multifocal IOLs, addressing even lower grades of astigmatism becomes extremely important. So while we just have a glance through our biometry, I actually have some examples. I thought we had less time, didn't show it. But if you, even a 0.7, 0.6 on the anterior cornea, because of the posterior corneal astigmatism, and even a low against the rule astigmatism can get potentiated by the posterior corneal astigmatism, resulting in a significant toric requirement. You may be surprised to see that even a very small 0.5, 0.6 on the anterior cornea against the rule gives you a T3 model with the toric calculator. So in case you don't input a toric multifocal or a toric monofocal, these patients will have a significant residual astigmatism, which will degrade both their distance and their near vision. So it's important to input all the regular patients into your Barrett toric calculator and then use the IOL as predicted by the toric calculator rather than just the universal 2.
Good. Any other questions for Shreyesh? I mean, Partha, would you like to go next? Are you in a hurry? Yeah, just load up. Just load up. I mean, yeah. I think as far as biometry, as we already emphasized, is the most important aspect as far as the basic premise of the workup of the patient is concerned. Are there any preoperative measures that you would adapt before doing the biometric examination of the patient as far as optimizing the ocular surface? We all know the importance of that before doing the surgery, but we believe it should be done even before a biometry. Would you like to talk something about the impact of the ocular surface before doing either an immersion A scan or an optical biometry?
So ideally in any setting, it would be best if this is being done on a pristine cornea. So essentially, when whoever is seeing the patient first, if example, if your optometrist is seeing the patient first and they're doing a retinoscopy, they find a dull glow, it's better that they first subject the patient to either an optical biometry, or if you're using an immersion, to an immersion, and especially take the K readings first. Most importantly, the keratometry first. And the reason is because once we do any contact procedure, like the applanation or any of the other procedures, or apply dilating drops, it breaks down the ocular surface, you start getting punctate erosions, and the repeatability of these keratometric measures go down. Apart from getting the accurate reading, even before you are seeing the patient or counseling the patient about various options, it's nice to have your IOL power printout. It tells you whether there is a toric requirement or an astigmatism requirement for this patient. And your entire explanation, counseling to the patient changes based on these inputs. So ideally, get the biometry done on a pristine cornea and get it done immediately after the patient walks into the hospital, and have it ready before you can